Okay, everyone. Welcome to our novel coronavirus practical measures for general practice staff today. It's a great number of attendees. Well done on this lovely warm evening. Just before we begin, I'd like to do an acknowledgement of country. The Northwestern Melbourne PHN would like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we're meeting today. We recognise their continuing connection to the land, waters and culture, and would like to pay our respects to elders past, present and emerging. Just some housekeeping for this evening. So the toilet, when the way you walked in, so if we're walking out to the lift, the left-hand side is the male toilets and the right-hand side is on, the female toilets are on the right-hand side. And we will need a key to actually get out of the toilet. So please, there's 2 keys here. Otherwise you'll be locked in there all night. No, I'm only kidding. Please, yeah, grab a key when you go to the toilet. If we need to evacuate, we evacuate by the stairwell, and we will direct you to where our meeting point is. Our meeting point is in front of the building at 369 Royal Parade, in the just in front of the grass area there. But we'll direct you right to the Royal Parade where the location is. So just watch out for the PHN staff. For those people that don't know me, my name is Sonia Zara and I work with the Quality Improvement Team as a Program Officer. Just before we get started, I'd just like to also welcome our webinar attendees and explain, and we will just explain the questions at the end of the presentation for those people that are on our that are watching the live webinar this evening. Again, welcome to the presentation today for the coronavirus update. So we just want to do a PHN update. At the moment, we have a fantastic QI project that's happening on eliminating hepatitis C in your practice. And it's a great opportunity and also has some great benefits. So 40 category points for GPs and some 10-cat training along with the project, and also compliant with the PIP-QI requirements that started last year. Also, just some updates on the P2 and surgical masks. The PHN received the initial shipment of P2 masks and has distributed them to all general practices within the catchment. There is currently an international shortage of surgical masks. We've had the masks supplied by the Victorian Department for the surgical masks, and the P2 masks were supplied by the federal department. The PHN has received a limited supply of surgical masks. These will be disseminated to practices on needs basis, focusing on practices with high risk populations. Recent announcement from the federal government that we will receive more masks, though no information provided as to how many and when. As soon as the PHN receives further information, we will relay this to practices across all communication channels, including network news, our general practice newsletter, etc. If you haven't opted in, or if you're not receiving any of our newsletters, please let your relationship manager know so we can get you subscribed to our newsletters. Please ensure you have read and are familiar with the department guidelines as well regarding the masks. I'd like to now introduce you to our presenter tonight, Margaret Jennings from Margin Education Services. Margaret Jennings has worked in microbiology labs, taught microbiology has conducted hospital clinical waste audits, provided a review in hospital disinfectants, and completed a recognised course with the Department of Health Vic for pre and post HIV testing. March provides infection prevention and control education to the primary health sector Australia-wide and has done so for over 20 years. This includes general practice, dental, podiatry, aged care, community and Aboriginal health. Thank you so much, Margaret, for coming to do this presentation at such a short notice as well. So thank you.
Don't clap. Might not be feeling like that at the end. I've got some my oversized business cards if you need to email me. And you know, with a session like tonight, you think, oh, did I hear that correctly? You know, and so you need to be able to focus a bit on where do I get my information from. So for everybody here, you are signed up or can sign into Pathways. Is that correct, Bianca? It's called Pathways or Health Pathways?
Yep, so there's an updated today coronavirus health pathway. We do need to change the name based on the name.
COVID-19, everybody. And we are very amenable to change.
On our website. So what you've got, the document that Margaret's holding up now is the full guideline, which is like the 24-page document that's available on DHHS. What we've given you as a handout is the GP reference, quick reference guide, which is a summary of that information. But that's all on our website as well as DHHS, and we will be circulating that with the email to everybody who has attended and also via webinar.
This has got information about what sort of swabs to take, when to put on a P2 respirator mask, and that's more to do with, does my patient have a pneumonia? My patient has obviously got to fit the criteria. I can't be just some random poor person with pneumonia. We've got to fit the criteria of travel and symptoms. Okay, so please appoint somebody in your practice, you know, somebody who is like that, who will log in of a morning or lunchtime and say, I'm up to date. Whoops, there's been a change. Okay, got to have somebody like that. There's no short way. This isn't Twitter, okay? This is us reading and understanding. So there's a whole page, I think you can see it here, the laboratory requirements. Now I can tell you before we really start, is that if you just decide, I'm going to take a sample, good luck getting it tested. So there's a protocol. And the first stage is to call DHHS when you have a suspect case. VIDRL, Victorian Infectious Disease Reference Laboratory, they're the only ones doing the testing. Don't send your poor patient to a local pathology. They'll shoot them out, okay? You will be required to take the testing at this point. You may, I would suggest, if your patient's really sick, elect to send them on, okay? That's, I can't see that anybody would object to that. If I've got a really sick person, regardless, there is another place for them and it might not be my clinic. Okay, whether they fit the criteria or not, obviously you'd phone ahead. So this is about, you know, good management of our seriously ill patients. So what can I tell you about this virus? Well, I can tell you that we do not have a registered disinfectant effective against this virus. So what we're doing is we're using the coronaviruses generally, MERS and SARS, among them, as our proxy for COVID-19. So we're saying that if a disinfectant has been shown to be active against those viruses, we will adopt it as theoretically effective. You can't do anything else. We do this with, say, Hep B. We can't grow Hep B, so we use duck Hep B as our proxy, and then we come up with our disinfectants. To be able to test against a disinfectant or an antiviral, you've got to be able to grow the virus. And as you're aware, that's only begun to just happen in the last 2 weeks. And I'm not sure that testing against disinfectants is going to be high priority, quite frankly. So this is what I'm going to suggest to you. Who's been to Dubrovnik on the Dalmatian coast? Come on, put your hand up. Let's skite. Let's skite. Okay. Now, Dubrovnik, that Dalmatian coast, that was a part of the Venetian Empire, okay, ruled from Venice. Any Italians here? Everybody knows where Venice is, okay? You've got that idea, it's up in that little corner there, and there's your Adriatic. Dubrovnik has got some old, you know, buildings on the top of the hill. The word quarantine in Old Venetian means 40 days. That's what they did to people. Up there, they have at their city gates fountains, and you are to wash your hands. You were to wash your hands before you enter the city each day. Dubrovnik was the only city, large city in Europe, that did not have the black. How can we translate that to 2020, everybody? I don't think it's difficult. And in fact, one of the things that we can probably begin to draw as a conclusion is that where we can enhance isolation and where we can enhance hand hygiene, it looks like we can slow down spread. You know, we can contain spread a lot more. So, you know, it's a very old lesson that I'm going to teach. So when your patients come in, don't go up and hug them. We're running a clinic, remember? Not a resort. And so social distancing. They might think that you've gone a bit strange, but you know what? I'm not running a resort. And you may be my neighbour and I can say hi, but this is a professional outfit. This is a healthcare facility. Last time I checked the funding agreement at my clinic, and social distancing. A metre at least from your patient's mouth. Well, you know, if they get up close to you and spit in your ear because of confidentiality, well, I want to put it to you. What's more important? You being at risk of coughs and colds and God knows what, and their confidentiality. I'll just leave it there. You'll probably have a lecture on confidentiality, you know, next week, and they'll say that that's not true. But no, you don't put yourselves at risk. So you have your metre. That's social distancing. Done that forever. The next thing, and this is just really normal, this is us reviewing how we operate in our clinic normally. So we have to like lift our game a bit. And I think that this virus is a good chance for us to improve our hygiene. Okay? And I think we're a little bit over seeing people cough in public without covering up. Don't you be that person. So cough like this, or if you're coughing to your tissue, alcohol hand rub. Okay. Patients coughing, mask. Thank you, mask. And maybe you have it, I was just saying to the group before, one clinic that I visited said, oh, when we hand our patients a mask, we don't touch the mask. We like them to know it's clean. So some poor little angel out the back puts, you know. But I thought that's good because you need to enable. You don't want a patient refusing a mask because you've touched it. Fair enough, fair enough. So I was pretty impressed, and they said, yes, and when they've used it, they put it back in the bag. I was very impressed. So for the webinar people, are they seeing or just listening?
They can see and they're listening, but do you mind moving a little bit closer to the computer because they are having.
They can't.
Some people can hear it really clearly,
okay.
others not so clear.
Well, that's going to be interesting because I'll move everything around. Okay. So what I'm doing is I've just got a surgical mask inside a little Glad bag. And as I said, some little slave in the clinic wraps a few of those up and passes them. So we don't want people refusing. So how tuned are you to knowing who's doing what in your waiting room? Okay. Oh, I can hear a cough. Excuse me, sir. We have a policy here. If you know, coughing, etc., we ask you to put a mask on. The person looks at you a bit strangely. Since when? Well, hopefully you've got a little sign up saying, you know, if you're coughing, sore throat, fever, whatever, ask for a mask. This is what we should be doing all the time. Okay, so time to go back to basics. What about our hand hygiene? So you all think that you've been given a free sample. Well, I'm going to make you work for it now. So how do you use your alcohol hand rub? If I were you, certainly as a nurse or a doctor, I wouldn't have any jewellery on. I need the alcohol to get to all aspects of my hand. Short nails, Long nails, everybody else's bugs will be under there. Short nails, just your bugs. That's why we like it, okay? No fake nails, no. And if you do wear jewellery, excuse me, not mounted jewellery. It'll go through your gloves. It'll perforate gloves, and it will just have dirt in the mount, and that will just inactivate the alcohol at that point, okay? So with your alcohols, tell yourselves what changes you're going to make when I do this. So I check, taking my jewellery off. I'm not going to wear that today, can't be bothered. The receptionist may choose to keep some on, but it's just going to take longer for your hand hygiene. So check your hands. Yep, my skin's intact. You know what it feels like when your skin's not intact, okay? Stings. And my nails aren't too long, fine. And my hands are clean. By the way, your hands need to look clean. You don't have to go and wash them. We only wash them if they look dirty, okay? But for our general being at the front desk for my clinical duties, alcohol is gold standard. It's not just an alternative to if you haven't got a tap, it's gold standard. We know that it's really effective against MRSA. Okay, so I put a little bit of a duck pond in there, and for me, the way I get under my nails is like that, okay? You guys can go like that, I don't mind. Now I spread the alcohol over my hands. Thank you. So they're wet, and I don't go like that. I rub the alcohol beyond the layer of grease, beyond a couple of layers of dead cells, and it should still be wet at 15 seconds. Just going sticky by about 20. We know that it takes about 20 seconds to knock off the flu virus. But if you walk past your alcohol pump and just go with one hand, squirt, fantastic, you've killed nothing. So I'm going to give you 30 seconds to have a look at the weight, review your own technique. Everybody's got a bottle, and if you haven't, some people have got two, so they might share. Some people have got two. Hand up if you've got two and just share. And those watching on the webinar, start doing your alcohol hand. And you can time yourself. Count. You can count 20 seconds. And of course, no need to write down anything, because this has just got to become second nature. But you'll be saying to yourself, oh, gosh, I've just not been using enough. Oh, gosh, I haven't been rubbing it in. You know, the technique. Oh, I've ignored my fingernails. So think about the people in Dubrovnik 600-700 years ago. They washed their hands at the fountain. They did not get that Yersinia pestis in, that particular bug. So we know something about isolation or social distancing, and we know something about hand hygiene from 700 years ago. So that's what we can do, okay? If you then look at our situation today, you say, well, you know, how do I know that the alcohol's effective? Because we know it's what we call an enveloped virus, and we know the enveloped viruses have got a little fatty coating on them, and they're susceptible to alcohol. It actually affects their attachment points on the cell, okay? So we know that the alcohol's effective, but you make the alcohol effective, and you make it effective against your cough and cold viruses. It's not so effective against norovirus gastro, but we're not going to worry ourselves right now. So the alcohol at the front desk, you know, a bottle for the patients, don't share, and a bottle for the staff. Okay, so we can actually reduce that touch contact. And I was saying to the last group, we touch our mouths alone, 6 to 8 times an hour. Okay, and so the last requirement for you to think about as a normal practice in normal situations is it's expected that we will wipe over with just a detergent wipe daily, end of the day, our what we call high touch or frequently touched surfaces. So you can imagine I'm walking into the clinic, I touch the handle, I touch the desk, you know, but as a patient, and the switches and the keypads like that. And so they are what we call our high touch or frequently touched surfaces. And the requirement is that they get wiped over. And of course, the cleaners will say, oh, so you want me to polish the doorknobs? But you see, they look clean. It's the floor that we focus on, but that's a different type of cleaning. That's very much aesthetics, the floor. This is a real infection control type of approach. So I don't actually always expect the cleaners to see it like that. And often the staff decide they're going to do their own desk. You know, at reception, the reception, not forgetting underneath. There's a beautiful little study they did with the over table in the hospital. You know, the patients have their over table and they watched the cleaners do the over table, clean, clean, clean. But of course, they didn't clean the bit that is touched all the time. Just have a think about that when you do your cleaning. So cleaning comes really last. So it's really hands, social distancing, and covering cough, that kind of thing. They're the really basic things that have possibly been missing in us. So I don't think it's fair that we try and blame others. Oh, their hygiene isn't fantastic or whatever. What are we doing in our clinic? So I think we can do a huge amount. The other consideration you have in your clinic is, well, actually, I'm here also to protect people who don't have many white cells, who don't have a great immune response. So I'm thinking of your patients on methotrexate for their rheumatoid arthritis. That is an immune suppressant. I'm thinking of your transplants. I'm thinking of your dialysis, diabetes patients, all of those. They don't need as many bacteria, viruses to get sick as you guys, the healthy people. They have a poorer outcome. And interestingly enough, because they can't clear these viruses as quickly, they actually still keep excreting them. So they're actually a risk to others for longer too. So that's about you recognising in my clinic, I've actually got maybe two groups of people, one of whom are a great risk to the other. Some with, you know, lack of immune competence, immune suppression, and others who are coughing everywhere. And I need to be protecting the ones who will come off second best. So that's why I ask people who are coughing or who present with sore throats and fevers to pop a mask on. Okay, I'm not thinking of myself, I'm not wanting to offend them. I'm actually wanting to protect the patients who are, I don't know who they are, but every clinic has got transplants, dialysis, people on methotrexate, etc., high dose corticosteroids, etc. All those people have an altered response, but will get sicker with less bugs. Okay, that's what we mean by vulnerable. So that's really your job. It's like conducting an orchestra, I think, in at the front desk. Now, there were some questions asked, and I'll just read these out to you because I think they're of interest to the people who end up doing the swabs. So I've dealt with reception a little bit, but I want to come back to you about what to do with my suspect patient with COVID-19. So I've just really spoken to you about general infection control at the front desk, but I do want to address the issue about swabs because that came through as 3 questions. And it said, this is from different people, can we send the patient swabs to our regular path company? No. Okay, there's only one lab doing the testing and that's Vidral down the road here. Okay. Do these swabs need to be throat, nasopharyngeal or sputum? So your guru, who you're going to appoint to check every day to see whether there's been a change at DHHS, if we go to page 17, it actually lists, here are the specimens, but please call us at Vidral or DHHS if you have a suspect case. And that's not just some random person who walks in off the street and says, I feel sick. Okay, people have got to fit the criteria of travel. It's really travel. It's not where you're from, it's travel. Okay, and where you've travelled to and when. So here you'll see it's all done in yellow for you if you download, you know, have a look in colour. And it says respiratory specimens, upper respiratory tract, nasopharyngeal. Now, do the patients cough, sneeze and whatever when you do those? Yeah, so you're going to have to be protected. But phone first. So the patient theoretically phones you and says, I'm coming because I'm not well and, you know, I am within the 14 days from being in China, etc. So it's quite strict. It's not just, I feel unwell. Do you think I've got coronavirus? You know, we've got to move on from that. So it's a nasopharyngeal swab is preferred, and people have asked what sort of swab. So it's a swab with a synthetic tip, polyester, Dacron, etc. Not a wooden swab stick. Okay, it's got to be aluminium or plastic, because some of the wood, or it's got substances that can inhibit the test. So the test that we do is a PCR, that stands for polymerase chain reaction, which means that you take the swab, and even if there's only a few particles of the viral RNA, it will actually amplify it. That's what the PCR does. It amplifies, and then the testing is a whole lot easier. It's really sensitive, super sensitive, so sensitive that you cannot get any of your own cells in the way. Okay, it's very, very sensitive. And it's sent in viral transport medium. Now, it's possible, you guys can educate me, that the special swabs you take already have some viral transport medium in the shaft, you know, in the tube. Have a read, go back and say, oh, is that what those swabs are? Okay, viral transport medium, often abbreviated to VTM. In the old days, I used to make that up in the virology lab at Fairfield, in little pink bottles. And we'd send them out and they'd break the wooden swab into the little bottle and screw the top on. That was the old days. Some of you weren't even born then, okay? But these days, it's usually the tube, and it's got some fluid in it. So have a look. It's not an ordinary swab. Or you may be sent special bottles with VTM, and you're told how to do it, okay? But be savvy and just say, oh, I should actually know this anyway. You know, so nothing different. Now, the other specimen from the respiratory tract, I think it's a bit tricky, this one, and this is about sputum. Now, in the lab, there's only one sort of sputum sample that we like. That's a really green, brown one. Okay, do not send spit. That's what we're sick of that. We're sick of that in the lab. Okay, it's got, if the person has pneumonia or something like that, it's usually a productive cough. If the person got a productive cough, we want stuff from down here, not here. Okay, we don't want spit. So I'm sorry if you've just had something to eat, but anyway. And the other specimen is blood. Now you might say, why do they want blood? Well, I think there's going to be a look back, where in months to come we might look back and see, you know, when antibody tests are developed, if we're actually producing an immune response with antibodies. I don't know whether this is going to be largely cell-mediated immunity or antibody-mediated. I don't know, because I don't know what it was with SARS or MERS. They also coronaviruses. So they do want you to take some blood. But going right back to the start, so it is listed there. This is what I do. I think the issue really is how far into this can I get as a clinic? At what point do I say, I just don't think I can put all this stuff on and take it off to doing a swab, but how can I make sure that I'm really serving my patients? You know, what's the likelihood, I think you mentioned, Bianca, if you are in a high-risk clinic. But right now where we are, we've got 2 or 3 days to go, and we'll know whether the people who've had the 14 days quarantine, whether they're okay. We're really waiting. So we've based that 14 days quarantine on what we understand to be the incubation period. So anybody who's been in contact with a known case or has been from that area, okay, and has symptoms, they're the people that we will swab. Now, what you may have, the people that you may have coming to you, and I've been doing some work out at the Monash clinics, is the students are really, really upset because they're worried for their families, okay, back home in China, really worried. Nobody's taking any notice of the sign that says don't come in. You can imagine, you know, people are pretty sort of strung out. The signs are in English. I've told them what I think about that. If I was strung out, if I was really anxious, I think I'd want the instructions in my mother tongue. That's me. Okay, that's me. I don't think that's unreasonable. But Monash have said, oh, that's, oh, oops, I shouldn't have said Monash, sorry, everybody. But they've said, look, you know, we're not wanting to discriminate, etc. But I think that has changed. And my husband said that one of the signs that went up in his lab said if you have a running nose, it's interesting, a running nose, okay, running away, okay, gorgeous. So, however, we've really got to reach out, absolutely no racism to be countenanced. You've got to call that out. If anybody starts, oh, you know, somebody from China. Well, it's not about being Chinese, it's about where you've been. So at this point in Australia, we've got no evidence of human to human spread. That means we are contained, we have contained. So your mantra is, I'm here as a healthcare worker or in the clinic to contain any suspect case. So how you do that at reception is a call's come through to the clinic. I'd like to come, I'm not well, and you know, I've been travelling. Some clinics are asking people, but right now we're pretty sure we know everybody, okay? And so the receptionist might say, just a minute, I'll pop you through to the nurse. It's absolutely okay to do that, okay? The nurse doctor might say, are you not well? Oh, well, actually, I just need some blood pressure, you know, medication. We don't know, you know. Can I say, in with all of this, we have the students returning who've actually also got flu, because it's flu season in the Northern Hemisphere. So, you know, it's not this just I'm focused on a possible, you know, outbreak. There is no pandemic. A pandemic means it's around the world and it's spreading person to person. We are not at that stage as of the 13th. Okay. So really trying to be understanding, thinking about what it must be like for people who have self-isolated. And if you know anything about people in an isolation room in the hospital, after 5 days, they're going crazy. Okay, so we have students who've been in self-isolation for 14 days. What contact are we making with them? Do we know who those people are? They our patients. Call them. Make sure they're hearing a human voice a few times a day. It's it can cause depression. Okay, so, and then they're worried about the family. So there's a real human context to that. Okay, who knows? They may need to speak to social workers, etc., etc. So that's the situation. The only time that they should come out is to come to the doctor, not shopping at Northland or somewhere like that. Thank you very much. Okay, so some of the, I know at the uni at Monash, they're dropping off care packs to the students, you know, soap and bits and pieces. Okay, but yeah, people are a bit lonely. It's a lonely thing. What do you think would make us alter the idea of the 14-day quarantine from the time you were last in China or had contact with a known case? Why would we alter the 14 days to longer or shorter? What factors? What would we learn about the virus? Well, if we said to people 14 days appears to be enough, they enter the community and then it spread. So you would have an idea, but that's not likely. From what we know already, 14 days appears to be a maximum. We might find that 10 days is enough. Okay? What might alter that is if somebody is about to reach their 14 days isolation, they get sick on day 12. Whoever has been with them, it's another 14 days for them. That's why you've got to feel for the people on the ship, okay? People on Christmas Island. At this point, like that. But that's exactly what quarantine is, and it's thousands of years old. The leper colonies of old, it's old, and we're doing it now, and, you know, as I said, can you imagine on that ship? So they're going to start testing and bringing out the people who have been on the inside cabins, no window for a week. Now you might go, oh, what are they complaining about? They've got to stay there. But you see the guy in England, he absconded. These are the things that happen. And all of us would be the same. Okay. Now,
how often are those passengers being tested?
The ones in Japan, just being tested now. So whether the kits whether they didn't have enough kits, I mean, these are they're doing, I think, a total of all the passengers, Okay.
How often? Every second day, third day?
Oh, you mean temperature or a proper throat swab? No, no, no. The throat swabs have only for the sick ones who've gone. So you've got, what, 3,000 people? Some amazing number. And they're going to start mass swabbing. But you've got to have 3,000 test kits. And CDC, that's Atlanta, Georgia, Centre for Disease Control, they sent them out to every country about 2 weeks ago. But of course, some countries will be testing more. Okay, it's interesting, Australia has more cases, say, than the UK. And that's because of our travel. It's not difficult. So we introduced our thing with the 1st of February well before the UK. Okay, my understanding. And I know a student who's been able to be accepted in the UK, whereas he was denied here. That's just the other day. Okay, so there's a bit of interest there. Yep.
Serology, what are we testing?
Well, in fact, we're going to have to be holding it or looking for other antibodies. The person may have something else. And if they've got influenza, who knows, they might have, you know, some marker there that tells us that. But we also don't know whether there's a viremic phase. I mean, I don't think they're doing any, you know, trying to sort of culture blood or anything. But I would say that's a look back, but I'm not the expert there. I was thinking, oh gosh, don't you mean you've got to do another thing with this poor person while you've got all your gear on? And I thought, oh no, that's going to be a look back. That's going to be a look back. Now, it wouldn't surprise me, as I think I mentioned, if they don't really spike much of an antibody response. It's going to just depend on what the virus, you know, does. The other thing we know about the virus or the infection is that the problems are occurring in the second week, not the first, which is where the virus moves down now, of course, is in pneumonia. We also know who largely is getting this, or who's getting the more serious, you know, consequences and dying. So it tend to be elderly and usually with underlying factors. So diabetes, hypertension, etc. Yep.
Sorry, so was that the second week after the first febrile?
Second week, you know, you would say.
Would you mind just repeating the question so the guys on the webinar?
Okay.
Sorry.
I've got a short-term memory issue here. So the people are presenting with a more serious illness, you know, they become more seriously ill in the second week. They don't present critically ill. It's taking another week or so for those people. But remember, I said it's not a broad group. It's a fairly narrow group, okay? So our job would be supportive care, IV treatment, etc., rest, pain, support, and of course isolation. So with the 14 people in Australia who have been hospitalised, you know, it would be next week that I would be thinking what's going on here, okay? So that's what you would be managing. So supportive care, there's no antivirals really at this point, okay? Even though they've been looking at a couple. In terms of vaccine, that would be another 6 to 18 months away. I don't think we're looking at that and whether a vaccine is possible. So you're looking at maybe a 2.5% mortality rate, but what we don't know and what blood tests stored now may show, if they do blood testing in the broader community at some point, we may even have an idea if people have had this without knowing and not been very infectious. What I can tell you is that the person who does have the pneumonia is excreting a lot of virus. And that's the concern for when you take a specimen and the person has pneumonia, you would put on a different sort of mask to what you would wear for the person hasn't got a productive cough. So I was going to show you that in a minute, how to put that on. Somebody in the last group raised the issue of a patient being turned away. And I thought that was a bit mean because I thought part of our mantra, we know how to protect ourselves. I don't think we're particularly putting ourselves at risk, but I'll tell you when healthcare workers are putting themselves at risk when they can't use their PPE and they actually self-infect. Now that will be happening. I could see on the telly the way people were touching their masks. This is healthcare workers. They're using their full suit, which I don't believe is essential, and they'll be just self-infecting as they take those off. And we know with us, the more we ask you to put on, there'll be a breach somehow. It's just really difficult. So I think the real question for you is, if my patient fits the category, you know, of possible, and it appears they've got a pneumonia because I'm on the phone in my room and they're in the room that they're put into when they come into my clinic, receptionist, we give the person a mask and we give them a room. We've got their mobile number. The doctor can be, you know, without going in, the doctor can get some history and decide whether he, she is going to put on all the stuff or the plain mask and the equipment, all right? How would it be, I put it to you, you've got to think this through. What if, oh look, I'll just put my plain mask on, my gown, which is required, my safety goggles, my gloves. I go in, I check the patient out, oh, they've got pneumonia. They are a suspect case and they have a pneumonia. I've got to come out, take all this off, put it on again with this. I think if I can get an idea and understanding, maybe I hear the person cough in the room, the door's closed by the way, but I'm on the phone and I'm talking to the patient in the other room. I'm thinking about how we can do this realistically, practically. And I'm saying to the patient, have you got a cough? Oh, have I got a cough? You know, okay, I'm going to be putting this on because this stuff is a menace to use. It could even be, your policy might be, you know what, this person's got a productive cough, they fit the criteria for a possible COVID-19. I actually don't think I want to take the specimen. I don't think I'm capable of putting on this stuff properly. And I might then call my hospital or call DHHS and say, this is my situation, and be guided by there. But I don't think I just refuse to see somebody. I think that's a little bit mean because, you know, they may have other issues. I also stressed to the other group, what is being said today, yes, can be altered by tomorrow. And I'll give you an example. DHHS say, put this on just when the person's doing the deep cough, you know, to get their sputum. But originally it was, if I'm just trying to think, the other one was if you're taking any specimens, put this on. So just keep listening because things do change a little. But if you've got your person who's completely OC and is right on to reading the instructions each lunchtime and how things have changed, you'll be right. Okay, so you have your little cheat sheet is here, okay, how to work out who their case is. I think people are also a little bit concerned about, am I a contact? Am I a casual contact or a real contact? And it tells you there how many hours and et cetera, et cetera. So can you see that?
Mark,
Yeah.
that's another question off the webinar.
Yeah, go for it.
The P2 mask that you picked up before, how long does that last for?
Well,
How long does it
technically,
protect you for?
okay,
Sorry.
technically hours and hours and hours, but being human, we touch it. So we change it between patients. So you wouldn't go to work wearing this and you wouldn't stand at reception wearing that, okay? Social distancing. What we know after, say, 6 weeks of this virus, what we know is that it's not like Ebola, where you needed so little of the virus. And Ebola has a huge mortality rate, huge. So I'm not underplaying 2.5% because that's significant. That's the same as, you know, influenza. Not only that, if you get people becoming seriously ill, a large proportion of those who get sick, if they become seriously ill and you do get a pandemic, that actually affects social structure. And I think you're seeing a little bit of that, you know, playing out even in China, where people begin to lose confidence in their health, you know, their healthcare system. In a pandemic situation with, say, influenza and a fairly nasty bug to boot, you begin to get absenteeism. And that would happen in your emergency services. So imagine if you have a bushfire and you want firemen there, but, oh, sorry, we have a pandemic and we've only got half the force. You know, they're the sort of things that people have been putting their mind to over the last few weeks. But there is no pandemic because it has been contained in each country. and so that it's not looking like Ebola at all. So when people say, what about your hair? You didn't cover your hair. It doesn't require that. And for you guys, your social distancing is in, you don't need to wear masks out there in public. If you read the definition of casual and you know, proper contact, you'll see that it doesn't, being in a supermarket doesn't meet the same criteria. I'm lying there. Does it say, oh, here we go, close or casual contact. You're going to have to look that up. There you go. You get that person to look it up, but it's right here. And for those of you who aren't going to look it up, I'll tell you what my close and personal contact is, but it's about how long and you're very close up and sharing time with them. Okay. Now, of course, when you need to find it quickly, you can't find it. All right, so you're going to have to do that. Well, I'm not going to bore you by doing that, but I am going to show you how to put on and take off your PPE. So in my world, I'd be thinking, I get my staff to really beef up on their hand hygiene. We're good with social distancing. We're not going to use privacy as a, you know, as a barrier. We're right on to sort of people coughing and spluttering. So they're the things that now we do normally. And gee, we haven't done a really good job the last 10 years since the last pandemic. So we've actually gotten really good at this. And then one day we get a call from a patient who says, I've travelled or I've been in contact with somebody who's a case and we're in action. So you say, just hold the line a minute. I'm going to pop you through to the nurse. That could be your policy. And then what I do is the person comes in. If it's been deemed they come in, you know, that they're not too sick, otherwise they should be in hospital. They come in, I know to give them a mask and I know to give them a room. The room, after they have left, the room stays. We don't have another patient in there for half an hour. So that'll be like 1 or 2 consults that we'll miss. And then I can put my stuff on with my ordinary mask and go in and clean. So I would clean just with detergent first, detergent wipe, the surfaces that have been coughed or touched by the patient. The patient's given a fresh mask and alcohol as they go out the door, or else call the ambulance, whatever. But at all times, you're in touch with the department. If you're going to take specimens, you've got to call the department first and vigil. I can tell you your specimens, if you send them in by taxi, will not be given a priority if you've not contacted the department first. So can you see that there's that strong link? You're not on your own. They will tell you. It won't be Uber.
That was just about getting the swab. Sorry, because they can't hear the question.
Oh, okay. So how do I get the swab to Vigil? They will instruct you. Okay, there'll be a method. They may even have a courier system. I don't know. Okay, and it may not be coming from Melbourne. I appreciate that.
Difficult situation where if we have somebody coming to our clinic who's febrile, who's travelled long haul flight
From
well,
a particular place.
It wasn't China.
Okay.
But we put him into a room,
Mm-hmm.
closed the door, he had a mask on.
Yep.
We asked the GP to go to that room to see that patient. He takes the patient out of that room, takes him into his consult room.
Okay, so this is about you've isolated the patient. The doctor's gone in. Did the doctor have a mask on? Okay, doctor no mask. Oh dear. And the doctor takes the patient out, but the doctor may have got some more information from the patient. I can't comment there, but this is what you're going to do. Okay, so if the person has got to be assessed, you might have been able to do a little bit outside in the phone, outside by phone. Not all patients are going to have fever. You've got to really work that out. And a few % are turning up with diarrhea only. Okay, that's also not unusual. So no, not everybody's getting a fever. And of course, in the elderly, that's one of the mechanisms that isn't always present. So this is how you're going to put on. Now I'm going to have to move away. Sorry, webinar people, but I'm going to be doing my hands, my alcohol. I'll use this one. Okay, so you're going to put on your stuff, and you've been advised by DHHS to take the specimens, and you've spoken to the patient by phone, and yes, they've got a chesty cough, so we're going to take the sputum in and we're going to take the viral swab, okay? Going to take a mask in to give the patient to come out with, and we also may, when we listen to them, we might think, you know, this person, they should be in hospital. I'm pretty sure that if somebody's got a pneumonia, that's where we're going to want to send them, okay? But we've got to listen and work that out as you guys, as doctors. So the first thing I do is I put on my gown. So we use what we call a fluid repellent gown. They're very cheap, about $1.20, but they are disposable. So we put that on, and that just means if somebody coughs on me, it doesn't go through. Okay? And of course, when you need to tie everything up quickly is when you're all thumbs and fingers, not fingers, but just thumbs. So we do that, and we treat the outside front of the gown as contaminated. Okay, not the back and not the inside. The next item we put on is our respirator mask. Now, the difference, people ask the difference. Yes, of course, one's thicker. But with my surgical mask, I'm actually not breathing through it. I'm breathing through the sides. The air's coming through the sides. This is great if I've got a cough or somebody's coughing at me, you know, or not even coughing at me, but, you know, it's stopping my droplets. But I'm actually breathing through the sides. You can see it doesn't, you don't get a seal. But with my P2 mask, I'm breathing through it, and there should be no leakage. All right, so to put it on, you'll notice that it's got two little ties, and you keep them separated, and you put it over your head, one on the crown, one band on the crown, and the other under the ear, so one above the ear. And you come around to the front, and about 1/3 of the way down the nose, push it in to fit it. So this is called fit testing. And as you breathe, the mask should collapse a bit. You shouldn't feel hot air racing out, okay? So you've done that. Pop your goggles on, Bunnings, $4, okay? Not bad because the virus can enter through the conjunctiva. Not as well as it does if you're inhaling, okay? Same with touch contact, but not as good as inhaling, okay? Then my gloves, what I need to make sure is that my gloves cover my cup, a good inch, good couple of centimetres above, okay? Always trickier with the second glove. And so, you know, the swabs are all labelled, the specimens labelled, the bloods are all labelled, and I go in. And I've got the bag there to pop everything in, and you can wipe things over with alcohol and whatever. But Vidral will describe, you know, what you do next. There, look, I'm doing my best shot there, but it's not fantastic. So I'm ready to go in, and you know, I do the nasopharyngeal, which is ticklish if you've had one, and the patient begins to cough and splutter. Okay, I'm more comfortable with this on. So I do that. Then I've done all my stuff. I ask the patient, here's, you know, there's a mask in a little bag. There's some alcohol. Just take the container, all right? I don't, you know, whatever. And I know that they've coughed and spluttered, so I'm going to have a contaminated surface. So I move to the edge of the door, which is where my bin, my yellow bin is, okay? And to take your gloves off, just pinch that top one, oops, and then inside. So I just don't get too much bug on me. Do my alcohol, always do your alcohol after you've, hopefully somebody, you know, can spare a bottle for you to contaminate. And then I'm going to go to my face. So I've got my hands clean. You can take your gown off, or you can take your eyes off. All I can tell you is you've got to leave your mask on to the end. Okay, so when you go to your face, you never touch the front. So across the back there. Okay, that can go into a bag to be washed or thrown out. I don't care. So you do the back, undo your ties, and probably put a knot in this, but there. Pull it off like that. and then down inside. All right, so you're not touching the outside of the front. All right, it's all inside, like that. To take this off, you grab the tool and then just out slowly. Feels good to get it off into the bin. Hands. So you've got to consider whether, how many swabs like this can I do per day? I've got a whole practice to run. But I show it to you because that's the correct way to do it. And you've got to say, you know what, I think we're going to have a triage here. And if the person fits the bill and they're unwell, I'm going to call Vigil, and I honestly think our best thing is to send them to hospital. They're the sort of things that are going to have to be worked out.
One of the webinar questions relates to that. Would you call the Department of Health line before physical examination or after physical examination if they fit the suspected criteria?
I would get some information first before I examine the person. So I'd want to know that they actually fit the criteria, right? I'd want to know why are they at my clinic? It could be for blood pressure medication, or they could say, I'm really worried. There's nothing wrong with me. I'm really worried. You know what I mean? Like, get some good information before you put this dramatic stuff on. Okay, that's.
And before you call the
the lady that I was with last week, she called the department twice during the 40 minutes of taking the swab. The person's presentation was diarrhea, and they had been in, it was less than 14 days, and that was just before they sort of did the quarantine. So you can see that we've already had people who've come back before, but none of them have been able to pass it on. Those who've got sick have not passed it on. So that tells us the strength of quarantine, hand hygiene, social, not social isolation, social distancing. And also, can I say, it's summer in Australia. These viruses love the cold. That's what keeps them infective. Whereas it's summer here, so I don't think they'll be remaining infective on surfaces out there for very long. Last question, the last thing I did want to cover just before I answer your questions is cleaning and disinfecting. So the person has now left the room. I can put on the same, not reuse the PPE, but put on the same PPE except go over to this mask, the surgical mask, and it's worn colour out, as I mentioned, and I can now clean the contaminated surfaces. So I don't do the curtains and blinds and windows. I think you can see the person's put their arms on the table there. What would the person have coughed on? What would they have touched? So we first of all wipe it down with detergent and paper towel or a detergent wipe, those surfaces. So you might go through 3 or 4 of the detergent wipes. Once you've actually cleaned, you can then apply a disinfectant or a disinfectant wipe. But you can't just go to every surface and run it over with disinfectant and say it's done. Disinfectants are affected by organic matter. So if somebody's put a lot of saliva on that, the desk, then that's actually got to be wiped off. And when you do use your disinfectant, it must stay in wet contact for a minute. None of this just wiping, fluffing around with a pint of clean wipe. Okay, your disinfectant will say it has activity against coronaviruses and or MERS and SARS. It cannot say it's got activity against COVID-19 as of today. Sure, that might change in a couple of weeks' time, but you're not looking at an organism, at a virus that's anywhere near the Ebola level. So have some confidence. The infectious dose we don't know, but it'll be much, much, much higher than Ebola. Okay, and Ebola was affecting people of all ages, healthy. This is not. Okay, I mean seriously. So okay, so some questions, and I'll repeat those for the webinar. People?
Just one on that.
Yep.
How long do you need to keep the room for, empty for?
Okay, no patients for half an hour. No, you can go in and clean in the 30 minutes as long as you've got your stuff on, but no patients for 30 minutes. Now, I've taken that off, just to be fair. I may not have seen that on DHH work, but that's from Lynn Gilbert and I think they're called the protection. They're people who work out, how much PPE to put on, and she's a respected microbiologist and she's been commissioned to look at that. So I don't think I'm sort of contradicting DHHS because we're really getting top information from where we can. But bear in mind that each country, each state even, may vary a bit. So where there's a gap in Victoria's, you know, you'd look at the national, but you can't override your state. You know, you stick with your state and then you might add, but you can't subtract. All right? And there were some questions. Yes.
There are two things. Do you need to gown when you're going to clean? And also,
Yes. Yep, you wear everything but this sort of a mask.
And also glasses aren't sufficient.
No, your own glasses. So this is you and I with our glasses on and somebody sneezing at us with God knows what. And now we're in the tea room cleaning them. No.
What about just the glasses?
Well,
The safety glasses instead of goggles.
interestingly, it also talks about shields. Okay, these are my preferred. Okay, you've really got to make sure you've got some reasonable fitting. It doesn't have to be goggles, but you'll see it says in the recommendations or goggles or safety glasses or whatever. Okay, and I've got to say, we're not. It's a precaution, but it's not as easy to get via the eyes as it is through inhaling. So it's droplet spread. The droplets fall quite quickly. Okay, not like measles that can take an hour or so and can infect everybody in the room if they're susceptible. You know, one measles person can infect 17 others. This looks like it can infect 2, but which is about the same as flu. Okay, so it's not as highly infectious, but we're just concerned about that second and possibly third week of how people are travelling. So yeah, you'd need to wear your goggles over that. So, and I think these are actually easier to wear over your glasses, but if you don't mind me saying. With the shields, I'm just not sure how you'd manage that. Okay. And there were another question. Yes.
If the patient is not sick enough to go into a hospital,
Mm-hmm.
they will take the swab.
Yep.
Yeah.
Okay. DHS will advise you, but I think if you read, you're going to be your person in your clinic, and I think you'll read, yes, I believe that they can go home. Okay. It'll be about how ill. I think that makes sense on 2 levels. Person's more comfortable at home, they're not seriously ill, but just keep tuned to DHHS because that could alter. It could go one way or the other. It could be, you know what, we've been admitting too many people. We actually didn't need to admit these people. They're doing really well at home because, you know, they don't have underlying factors, whatever. So at this point, we are admitting people who actually have it. All right. Now that I may have to correct myself there. Just look that up, all right? But remember, it's a real-time thing, but you can imagine we couldn't hospitalise everybody. So at this point, the 14 people, did they all go to hospital, the Victorian people? I think you'd want to get a pretty good look. Yeah, some might have gone home. Yeah, you'd want to get a pretty good look at people. You know, how are they? Because this is important for us, you know, like research-wise. How is it that people travel through those 1-2 weeks? But you can see the problem with people going to hospital when they're not that sick is, well, we're trying to minimise spread of infection here too. Okay. Yeah.
How do you discuss of the use?
Use PPE, it goes into the yellow bag, tied off. Okay. And of course, we know that that is not compressed. That's collected. I don't think there's any special provision. It just says clinical waste.
Yeah.
Okay. Any waste from somebody with significant clinical, significant infectious disease, all goes to yellow waste. Okay.
There's a question about, is Glen 20 spray just as effective as disinfectant wipes?
I think
Please
it's
repeat
okay. Is
Sorry.
Glen 20 just as effective as the disinfectant wipes? Well, obviously somebody has read the label on the Glen 20 and it may say it kills 99.9% of something. The active ingredient, I think, is benzalkonium chloride, which is in Pinoclean anyway. Yeah, it's the same thing. And I don't know whether that has activity. It possibly does, but spraying through the air, I think we need to think about people who have reactions to inhaling that stuff. You know, in the clinic, I think one of the reasons why we use it is just for smell nice. I think there are other ways we can do it. I'm a bit concerned about the level of chemical usage in clinics. As you get older, you can begin to have more skin reactions to stuff, and No, I probably wouldn't welcome Glen 20 at all. Maybe for a spray in the toilet if you really have to, okay? But it's a deodorizer. At that concentration, it's a deodorizer, not a disinfectant.
Sorry, just a couple more of the webinar. Is Tamiflu being used?
They were trialling that, I think, in Thailand, and then no more word. So no, at this point we say that there is no effective antiviral treatment. It's supportive treatment, okay? And it seems to be, as I said, people in that second week who develop the pneumonia, they have got a huge viral load, a big viral load, okay? And that's why they need the P2 mask.
And sorry, just you might have said this and I might have missed it. How long the virus can stay on the surface?
How long can the virus remain infected? Well, given that viruses aren't alive, I think I might have mentioned that, we'd say how long are they infected for. But whilst you might say, oh, I've proven that I can recover reproducible particles 4 weeks later, for example. People want to say that about norovirus. I'm not talking about COVID because we don't know, but people will say, oh, did you know that norovirus particles, they can stick around for 28 days? Well, the fact is, their ability to infect drops off. So you may recover a few particles after 28 days, but is there enough to cause an infection? Probably not. So we know that with that surface stuff, it's the cold dry that they like, and that's not our situation. It's humid and warm, quite the opposite, so that doesn't favour it remaining that infective on surfaces. But our best practice is to wipe over that coughed and touched surface. Don't worry about the carpet. Nobody's getting sick from the carpet, okay? But don't ever feel in this that I don't know who to call. It's DHHS and it's Vidral. Don't send specimens without contacting. Okay, so it's your first port of call. And if you're at reception, you've got your nurses and doctors, and it's okay for us to flap around the first time it happens. That's what we're like. And then we go, you know what, we've got to get our act together. We've got to get our policy. Nobody gets a policy, you know, happening till their first person walking in the door. And I think too, you would remember the first case in Melbourne, which was on the other side of Melbourne. The doctor sent the patient home. Now, I think any of us might have done that because we can't believe that we would be the first, but somebody has got to be the first GP. Somebody has got to be. But inside of us, we think, I don't know, it's not going to happen. But you need to be alert. But our mission is contain. Okay, and please only use your masks once. Okay, don't shove them in your pocket or anything like that. Now, how have we gone? I think we're done. But I'm unforgiving. Please put somebody in charge of this and accept that it may change on a twice weekly basis. It's changed its name to COVID, which is COVID, coronavirus disease 19. All right. Does anybody want to ask about how it's emerged?
Yes.
Beautiful. Okay. So the coronaviruses, there are human coronaviruses, there are animal coronaviruses. Okay. So see, a virus doesn't want to knock everybody off. It's not in its interest. Its interest is the best viruses in the world over history have become less pathogenic. They live quite happily with us. Okay, cause a little bit of infection, but that's the way. It doesn't work for a virus to knock everybody off because it's now got nobody to live in. All right, so, and this will be a number of months working its way through the system, probably even a bit longer. Sorry, what was that initial question?
Where did it come from?
Okay, so probably through bats. The Middle Eastern respiratory is bats through camels, most likely. That's been postulated. And SARS also. So bats seem to be a reservoir. So you need a species jump. And to do that, there needs to be little welcome mats on our cells, our respiratory cells, to say, come on in. So a lot of the animal viruses cannot infect us. We don't share enough. The virus can't get in because, okay, you think about your dogs. Do you have your pets vaccinated for canine distemper? So that's a virus that cannot infect humans. You can't catch that. That's just a dog. But where a virus can infect both animals and humans, you know, it can be a zoonosis, and it can jump species. It might take a few mutations for it to be able to jump species, but this one has. So the first cases were among people who were in the wet market in Wuhan. So that was the fish market, and they were washing down everything, you know, at the end of the day. So they said, oh, could it come from fish? But that's not likely. That's a big species jump. You know, mammals, bats to us is a mammal, that's fine, but fish to humans, it's a bit weird. But they believe it actually came from other parts of the market, not the fish, okay? And people were then exposed to, you know, you can imagine you're hosing something down and you can feel the splash. And so it seemed that it came from other parts of the market, okay? Possibly other animals. And I don't know whether you know, but eating wildlife can be seen as a prestige thing. I like kangaroo myself, and I know that it's got 4 times the amount of iron as beef, and it's a very lean meat. So I'm in disgrace eating our national emblem, but in other countries of the world, it's a sign of prestige. You eat bats. You eat, okay? We're no different. Have you had any possum steak lately? You can get possum steak down at Leo's. Tastes awful. Okay.
Sorry, there was one last one from the webinar. What type of surgical gown to wear?
Okay, it's just called a fluid repellent gown. So theoretically, a plastic gown would be okay, but the ones I've got here, they're like $1.20, and they're just called fluid repellent. Isolation gown, they've got all sorts of names. Okay, but the signature is they've got a cuff that you can put your gloves over, and they tie at the back. Okay. Is that? I think that's it.
That's all from the webinar.
Okay, but remember, I'm not the last word. This is. Okay. Thank you.
Thank you. Thank you. Thank you, Margaret. That was a very informative presentation. Thank you so much. There was lots and lots of questions, which was awesome, you know, from the audience as well as the webinar. So fantastic presentation. Just before you all leave today, I just want to say a big thank you to all of you for coming. Also for our previous presentation, and for all the attendees on our webinar, thank you for attending. I also would like to say in the coming days, you will receive a Survey Monkey link for this